Live in a box tri-clip case. So this is the history of the patient. It's an 80-year-old female with symptoms of heart failure and white checklist class 3 and 4 because she had a hospitalization for peripheral edema requiring IV diuretics, chronic atrial fibrillation patient with severe massive tricuspid regurgitation, preserved ejection fraction, mild mitral regurgitation, and normal aortic valve. And if you look at the right heart catheterization, you can see that there was only moderately increased pulmonary hypertension. The wedge pressure, the mean wedge pressure was less than 20, so it's a triluminate type of patient following the presentation that we had before, with a significant elevation of the pressures on the right side. And the Euroscore tool for intervention of the tricuspid valve was 6%. But we all know that Euroscore may underestimate this population. So I'll just present some echo images. This is the valve. And please, I would like the panel's feedback on that. So you can see the septal leaflet. This is a transgastric view. This is the anterior leaflet. You can see the anterior leaflet is divided. There is an anterior scallop and a mid scallop, and there's also a posterior leaflet. So following to what we were discussing before, this is a quadricuspid valve, and you can see that the jet is coming exactly at the origin between the two scallops of the anterior leaflet and the septal leaflet. So it's an anteroseptal location, more central than commissural, but with a divided leaflet. However, the length of the leaflets, as you can see here in this X-plane view, so we use this view that we called RVO view, right ventricular inflow-outflow view, what we also refer to as the commissural view of the tricuspid valve. And this way you can use your cursor and using the X-plane or multi-D, depending on what equipment you have. This is multi-D from G. You can see the leaflets on their perpendicular orthogonal plane. You can see you have long leaflets, and the coaptation gap is not that big. Here is another view of that. You can see the length of the leaflets on the right side, quite long leaflets. The septal leaflet is almost 20 millimeters long. So following the conversation before, it's quite interesting that this is a valve that has some advantageous features for tricuspid clipping, like long leaflets, anteroseptal location, not big gap, but it's a quadricuspid configuration. And you can see at the top right here, on the panel, the quadricuspid configuration here, the images are even better during the case. So we were aiming to put a clip in the anterior scallop of the anterior leaflet and the septal in this location, and then a second clip in the middle scallop of the anterior leaflet and the septal. And we will try to put them in a V configuration in such a way that the indentation, you can see the indentation here, Elias is showing that very nicely, this indentation will converge, will not open. So the setup is what we normally do. We have a 6 French femoral venous access that we always obtain with ultrasound. We have an arterial access for the arterial pressure on the right arm, patient under GA, intubated, TE in place. And we go up with a multipurpose catheter just to obtain position in the superior vena cava. You will see in a minute the fluoro images. So wire up in the SVC, and then we prepare the clip. Quite frequently, see the coaptation gap there is being measured and the length of the leaflets. We always obtain these measurements on the bedside. And what we do is we use XTW for these cases, so the big and the wide clip. Now this is the steerable guide catheter inserted into the right atrium. You can see here, we put the stabilizer to stabilize the position. And in a minute, we're going to remove the guide wire and the dilator to maintain the position. It's the same process that we do for the mitral valve. Make sure we do de-airing. So dilator comes back, wire comes back, and then with aspiration, we will remove the dilator. So dilator comes back, aspiration of blood, and then flush. So we want to maintain the position of the guide catheter in the lower part of the right atrium, lower to middle part. The most important thing is for this big sheath is to be visible on echo. You can see now on echo in the bicaval view, the steerable guide catheter is in position and we're very clear to see it. We don't want to do anything without seeing on echo because we don't want to impinge on sensitive structures such as the septum or the free wall of the right atrium or the right atrial appendage because that could be a disaster. So now CDS delivery system is inserted. You can see here. There's a blue-to-blue line, is aligned with the system. And what is interesting with this configuration is that the catheter is modified for the tricuspid position versus the mitral. There's a dual steering capability. So this catheter can be flexed down to the valve, and there's a lateral flexion. What we need is for the clip to be inserted to achieve the straddling position, and we always follow the clip position, the tip of the clip, to make sure we don't impinge on the septum. So we avoid impinging on the septum. So here we have achieved the position of the clip, the straddling position there. And now we are going to flex down the clip down to the tricuspid valve. The good thing about tricuspid intervention versus mitral interventions is that within a few minutes, you're on top of the tricuspid valve. You don't have the transeptal puncture. You don't worry about clots that much because you work on the right side. Of course, you have to take care. But really, within a few seconds, you're above the the tricuspid valve. You can see here. So what we want now, and that's the most difficult part, is the imaging. Now, imaging has to be pristine. We have to be precise. And we take every effort to get imaging. So we are trying to attack the location that we're more interested, where the color is. Here we have opened the arms already, and we have checked the independent grasping. We can see, for example, here that it is the anterior part of the clip that moves. We see that our clip is above the collar zone here, and we just push the clip above the leaflets, almost touching the leaflets. We want not to cross the leaflets. So here is the independent grasping. It was a septal leaflet, actually, not the anterior. We want the clip to be above the leaflets so that when we go into the stomach for the transgastric view, to assess the perpendicularity and the exact location above the tricuspid valve. So it takes some time. We need to spend some time to get the view right. Here, you can see on the top right. But you remember the two zones that we were attacking, the anterior zone and the central zone. So we want our clip, which is now widely open, to be in the anterior zone. So here, for example, is more central than we would like. So we're going to push more anterior, and we're going to rotate a little bit counterclockwise to respect the line of coaptation. Here is almost in the central zone. But we do all these maneuvers very, very carefully. We don't rush. It's not a TAVI procedure. We don't have rapid pacing. Hemodynamics are very stable for this patient. See how we're clocking this device, making sure we have it. And now it's being pushed anterior. And there's always a discussion with echo. This is interventional cardiologist makes few decisions on this procedure. The echo is the boss, I'm telling you. Echo will tell you what to do. If echo is not happy, you're not happy. So this is the position. So we have widely open arms. We're in the anterior zone. So once we're happy with the configuration, we will go back to the mid-esophageal view here. We'll spend a few seconds or minutes even to optimize the pictures. It's very, very important to get the best views available. What we normally do on the fluoro is we move the camera in such a way that we see almost a single line of the arms here. So we don't want to see on the fluoro the arms open. We want them to see overlapping each other. And the reason for that is this is our security of perpendicularity. Now we close the arms. You can see on the top right, we close the arms. and we will move in towards the ventricle. We always move with the arms of the clip closed. And very careful, we don't want to go too deep, just below the leaflets, there. And we open the arms again, and we look on fluoro, make sure we don't rotate. See? So we have the single line configuration here. So now we're in a position to grasp. And really, we wanted to do first attempt. We don't want to open and close, because we don't want to damage the leaflets. Tricuspid leaflets are generally thinner and more sensitive than the mitral leaflets. We double check again on the transgastric view, make sure we haven't lost our location on moving in, we haven't lost our perpendicularity. And now you can see the leaflets going in here on the right. We take our time. We want the leaflets to go flat on the arms, to be immobilized by the arms. Anterior leaflet is long, is in. Septal leaflet is definitely in. Now we're going to drop the grippers in a minute. We take our time. Sometimes we have to rotate, adjust the perpendicularity. It's fine movements. Echo has to follow. That's the most difficult part, millimeter by millimeter. Now you see the leaflets are flat. We're happy. We drop the grippers and we slowly close the arms of the clip, releasing some tension. And now you can see the clip closes. The leaflets are immobilized. We record this so that we're able to see. And that's a good grasping. You see that the leaflets are coming horizontally into the clip. They're immobilized. And this anterior part of the valve here you can see is already clipped. We will check it in the transgastric view, of course. So that's a useful view to see how the leaflets are being inserted into the clip. So the anterior leaflet and the septal leaflet are creating angulation and they're falling into the clip. So that's a good sign that we have enough grasping. And of course, we're left with the central part of the valve now, open. We will see in a minute. We always record the grasping. This is the recorded part of the grasping. We take a look at it. It's worth spending a minute or two on that because sometimes by closing, a few millimeters of the leaflet may slip out of the clip. So this is the recording. We're checking again. We're happy with that. And then in a minute, we're going to release. I'll just move a little bit forward. This is reviewing of the grasping. So now this is the release process. We're doing some handling here, taking the line, the lock line, the gripper line out. And while we're doing this, you can see eyes are on the clip. Make sure it doesn't move, it doesn't rotate, and also fluoro helps to sustain our position. And in a few minutes, you will see the clip to be released. That's it. So now clip is released, and we will assess the result. I'll just move in a little bit. See, now you see there is another color jet coming from the medial part of the valve, the one that is central, I would say. And this is anticipated, so in a minute we're going to put another clip in there. And we're just going to prepare the clip. This is the clip. Now, putting a second clip as in the mitral position is actually quite easy to do, easier than the first one usually, because you have your first one as a marker. So the same maneuvers again, clip goes in, but you have your reference point. So we want to go central. that is posterior. Posterior means on the fluoro, we're going to go below the first clip. And we, of course, have the marker, the clip as a marker, but we're going to do the same maneuver. So we have eyes on the guide and the tip of the clip. We don't move before echo sees us. Of course, now clip is out, and we're bending, we're flexing down towards the tricuspid valve. And usually this is a maneuver that on tricuspid it can be done within seconds. It's easier than the mitral because the excursion is shorter and there's usually more space in the right atrium, plus you have your clip now as a marker. So now we're bending down towards the tricuspid valve and the clip, and we can always use the configuration of the first clip to guide the second clip. So in terms of perpendicularity, the clip is in this position, so we will rotate the clip, the second clip, to have a similar configuration. We want it to be as parallel as possible, and of course on echo, we will direct it to be above the zone of the collar, so centrally posterior to the other clip. And once we're in position, we will go down to the transgastric view. Of course, now we're opening the arms again. We're making sure our trajectory is right. We're above the collar zone. Now you can see the arms are open there. We will check the independent grasping. We will go above the valve. Same as before. Now we're going to move inside the stomach. You can see where the clip is, top right. It's a little bit more posterior than we would like. There is a big distance between the two clips, so we will move anterior, we'll push in, and then we will rotate this second clip to get a perpendicular sort of configuration. So looking at it, it has to go a little bit counterclockwise, which we will do in a minute, but we just take care not to impinge on the leaflets, not to move too anterior or too posterior. And now we've done that, and we're about to go down to the valve and grasp. We close the clip, we dive in, we always take care to go in a parallel fashion to the other clip, eyes on the fluoro and the echo, open the arms again. Now we're below the leaflets. So we give the echo a few minutes to adjust the view because the probe moves all the time, so it's not easy. And now we're above the grasping zone. You can see where the anterior leaflet is and where the septal leaflet is. And we're trying to get both in if we can. We did that in the first grasping, closer to the commissure, but here the diameter of the valve is bigger, and sometimes it's not easy to get both leaflets in, and sometimes you have to make a decision to go for independent grasping. And I think this is what we did in this case. So you can see now we're trying to get the anterior leaflet in. So the grippers are down on the anterior leaflet. And once we're happy that we mobilize the anterior leaflet, we move to the septal leaflet. We need to get enough septal leaflet. Once we're happy, we're going to get the grippers down on the septal leaflet, and now closely we're going to close the clip. We need to make sure when we close it we don't have tension on the leaflet, so we push in the handle, we correct the clockwise counterclockwise rotation, and look now what is happening to the right atrium. There's dense smoke. That is an indication that the tricuspid regurgitation has been taken care of, and this is the immediate color that you can see. Now we have practically trace of TR. So we will assess again the leaflet insertion. The most important thing is to go into the transgastric view here to see really that what we set as a target has been accomplished. So we have one clip anteriorly and another clip in this middle segment scallop of the anterior leaflet, and the posterior part of the valve is still widely open. And this is the color from the transgastric view, only a trace in between the two clips. So this cleft between the two scallops of the anterior leaflet actually is not open yet. Okay, and I think this is pretty much it. For the interest of time, I will just this is the release of the clip, you can see, and this is the final result on the transgastric view there. And that's pretty much it. Patient did very well, went home in 2 days, and overall the result was excellent. So thank you very much for your attention.
Well, I have to say this is amazing technique and amazing imaging. So congrats to both of you. It's amazing, but of course you have to have the proper hardware, right? You cannot do these procedures without the appropriate hardware. So it's very important to have the proper echocardiographic machine to know how to use. And since we are talking about knowledge, I have to inform you, also people from the web, that there are concurrent sessions in workshops regarding the 3D TOE usage in the whole day in the adjacent room. So please be free to join the workshop. And Dr. Grapsa, who is coming from St. Thomas, who has a special knowledge in doing these workshops, she will use this opportunity to make to make this educational content more feasible to other colleagues. So, Julia.
Thank you so much for giving us this opportunity to do the hands-on. And, that was a great case. Congratulations to both of you. Just for the sake of time, just a few things that how the imager is in contact always with the interventionalist. Yeah. Like, you change position quite quickly. And if you get a chance, come and meet us at the next door that we are going to the workshops.
Okay. So thank you, Vlasi. We have to leave it there.